And in the end of the second phase, we are going to do that as well, right? So that we are going to incorporate divine intervention audio podcast within the schedules. So those who want to, like, listen to that, so you guys can just start if you guys have any free time, right? Divine interventions podcast on Google. You can just search it. Is that clear? Hello.
Yes, thank you.
Okay.
So, what are you saying about Divine Intervention podcast?
Yeah, he just said about it.
Hello. Can you guys hear me? Hello. Can you guys hear me?
Yes.
Can hear you just fine now.
Okay, perfect, right? So today we'll be starting an important module, that is white blood cells. So believe me, right after this session, you will be able to answer each and every MCQ, even on your UWord, on your exam day. But I have a strategy for that, right? So before starting the WBC module in detail, first of all, I want to discuss some of the terminology that we will be using for the future and the concept behind it, right? So we'll be starting with some of the terminology, but before, tell me what Okay. So can you guys just tell me that white blood cells comes from where? From where do we have like origination of white blood cells? Yes, anyone?
Bone marrow.
Bone marrow, or can I say from hematopoietic stem cell CD34, right? So they arises from CD34 hematopoietic stem cell. Okay. We also have like a range of normal white blood cell count, and that's basically from 4K to 11K, right?
Dr. Ahmad, your
Yes.
We
screen.
can.
Okay,
Not
so sorry,
visible.
so sorry. Let me just share my screen. Okay. Can you guys just see my screen now?
Yes.
Perfect.
Okay. Okay, that's perfect. Okay. So whenever the white blood cells increase from its reference number, like greater than 11K, so basically we use a term for that. And what's the name of that term? Leukocytosis, right?
Yes.
Leukocytosis. What are leukocytes? Like leucos stands for white, right? White blood cells. And cytosis, that is increase than its reference number, that is 11K. So whenever we have increased WBCs, like we're going to discuss some of the condition in which you can have increased white blood cells. So the term used for that is going to be leukocytosis, right? However, if we have less than this reference number of WBC, so basically we use a term for that, that is leukopenia, right? Hello.
Yes.
Yes.
Okay, perfect. So let's discuss leukopenia and some of the causes of leukopenia, right? So it's going to be so simple, right? So for example, we know that neutrophils are also your white blood cells, right? They are your white blood cells. They are your policemen of your body, right? So whenever we have decreased neutrophils, so basically we are going to use a term for that, that is neutropenia, right? So less than 4K of like neutrophils or the reference, right? Reference number of neutrophils, we are going to use a term that is neutropenia, right? So what can cause neutropenia? The idea is really simple. Anything which can damage your hematopoietic stem cell CD34. Can I say that it would lead to neutropenia?
Yes.
Okay. So what things just damages your hematopoietic stem cell? For example, chemotherapy, right? What's the idea of chemotherapy? Basically the idea is like, for example, if you have an individual, he's having some neoplastic condition, so we basically just put him on chemotherapy, right? So the idea of chemotherapy is to decrease the division of actively dividing cells, right? Or for example the cancer cells. But neutrophils and white blood cells are also actively dividing cells, so the number of these cells can also be decreased. So can I say that chemotherapy can lead to neutropenia or lymphopenia? Okay, leukopenia. Can I say that?
Yes.
Okay. Along with that, some alkylating agent, which are basically used as a therapy for your cancer cells, can also cause leukopenia. Is that right? And besides that, severe infection, right? Not a simple infection or a normal infection. Severe infection can also lead to leukopenia. How? Like for example, let's suppose like I have a tissue, right? And we have blood vessels running in between that tissue. For example, if I have an infection going on here, so what happens? All of your white blood cells from the blood are going to go inside the site of infection, for example the tissue, right? So what happens here? If all of the white blood cells are leaving the blood vessels, entering into the site of infection, so can I say that I can have leukopenia in my blood?
Yes.
Perfect, because in severe infection, if it's severe, you need a lot of white blood cells to be there, right? So it can also lead to leukopenia, right? Is that right? So another term basically which we are going to use is lymphopenia. What do we mean by lymphopenia? Whenever the number of your lymphocytes are less. So we discussed you have like B lymphocytes and T lymphocytes. You already know that, right? So whenever they are less in number, basically we are going to use the term lymphopenia for that. Is that clear? For example, we discussed a pathology, D-George syndrome, right? What happened in D-George syndrome? We discussed. You got MCQ on that. Thymic aplasia, right? Are you guys able to understand? Are you guys following me?
Yes, sir.
Okay. So if we do not have thymus, so can I say that now the T cells cannot be matured? T cells cannot be matured. If T cells aren't mature, so can I say now I'm going to see lymphopenia because I do not have mature T cells? Lymphocytes are less. Can I say that? Hello?
Yes.
Okay. If you guys remember in endocrinology section, we discussed cortisol. Remember cortisol or glucocorticoids? We discussed that glucocorticoids are also anti-inflammatory. Did you guys remember that? It does two things if you remember. What would it do? It would decrease your immunity, right? By suppressing the quantity of or number of your lymphocytes. So can I say that cortisolism or Cushing disease, in which we have increased cortisol, can also lead to lymphopenia or leukopenia? Can I say that?
Yes.
Perfect. Another disease which we discussed, SLE. What happens in SLE? Remember, type 2 hypersensitivity, killing all of your cells, including your red blood cells, your white blood cells. Remember, can I say that? In SLE, again, I can see leukopenia or lymphopenia. Can I say that? Can I say that?
Yes.
Hello?
Yes, sir.
Okay, perfect. Another thing which we discussed, for example, if you have an individual again, like he's having some neoplastic condition, so we can have two approaches, either to give him chemotherapy or radiotherapy. So, for example, if I'm giving, or what's the idea of both chemotherapy and radiotherapy? It decreases the activity or division of your actively dividing cells, and white blood cells are actively dividing cells. So, radiotherapy can also cause lymphopenia or leukopenia. Can I say that?
Yes.
Okay. Then another term which we'll be using is leukocytosis, right? So we already discussed what is leukocytosis when we have greater than 11K white blood cells. How can we have that? How can we have that? For example, if I have a bacterial infection, not severe infection, right? A moderate kind of bacterial infection. So it's obvious that your white blood cell concentration is going to be more in order to fight off that infection. Can I say that? So bacterial infection, right? But this time it should be like a moderate kind of, right? Not severe. Are you guys able to understand?
Yes.
Okay, so bacterial infection can also cause leukocytosis. So these were some general terms which we used and which we already know, right? So the next pathology which we are going to discuss is infectious mononucleosis. I would say a yes shield topic for today, right? Because you are going to see a lot of MCQs in your world. So you guys should have an idea what is infectious mononucleosis or IMV. Whenever the term IMV came, so there are some things associated which should directly hit on your brain, right? So IMV, also known as, yes, kissing disease. Did you guys remember? Did you guys did the microbiology of that? Hello?
Yes. Yes.
Okay, so the kissing disease, if you remember, and which bug is responsible for that, or which virus is responsible for that? EBV, right? Epstein-Barr virus. Do you guys remember?
Yes, yes.
Okay, perfect. And besides that, CMV can also do that, cytomegalovirus, right? Okay,
Yes.
so what's the idea of this pathology? What are you going to see? This virus is going to infect three things. Remember that, right? So it's going to infect three places or three things. The host for them is going to be three thing or three places. The first one you guys know, B cells, right? That is CD21 receptor. CD21 receptor is present on B cells. You already know that the higher number of receptor for B cell and the lower number of receptor for T cells. Is that right?
Yes. Right.
Okay, perfect. If it's infecting your B cells, okay, so this is going to be the first site or the first location which EBV virus loves to attack or infect. The second thing which you guys should remember, the mucosa of your pharynx, right? Giving you pharyngitis. Is that clear?
Yes.
Or
Yes.
mucosa of your oropharynx, right? So pharynx or oropharynx, let me be very specific, right? So this is the second location where EBV is going to go. It's going to infect the mucus and it would appear in the form of pharyngitis. And besides that, you already know that normally the viruses, give you upper respiratory symptoms, right? It's a general, theme and general concept which you guys should be aware of, right? So you can just simply remember it like that. Is that clear? And the third place is going to be your liver, right? So it's also going to attach the liver, in especially the macrophages, right? The Kupffer cells. You already know that macrophages within the liver are known as Kupffer cells. Is that clear?
Yes.
Hello? Okay, so let me repeat it again. Infectious mononucleosis. It's a virus, right? Virus. And whenever we see the term virus, so can you guys just tell me which cells are going to fight off against virus based on immunology concepts? Yes. Which lymphocytes?
CD8 T cells.
Okay, so can I say simply T lymphocytes?
Yes.
Yes.
Okay, perfect. But here you guys can see, although this virus is attacking your B cells, you guys can see the receptor CD21, right? But in response to that, your T cells are going to come and it's going to fight off this infection. Is that clear? I'm just pointing out an important concept, right? A lot of students get confused in this. Let me just repeat it again. This virus, the host for this virus is going to be your B cells, but the body would respond in such a way that it would, initiate a T cell response, cytotoxic T cell response. Is that clear?
Yes, sir.
Yeah.
So you have a UWorld MCQ. They're going to ask you that we have an individual. Okay, we'll be discussing the presenting features based on these three locations, right? Don't worry about that. So if you have an individual, you have EBV. So in the blood, which cells are which abundant or which atypical or abundant cells I'm going to see? Yes. So you guys are going to tell me B cells or T cells?
T cell.
T cells, because you need a lot of T cells in order to fight off that infection. So you don't have to confuse it with B cells. The host for it is B cells, but the body would fight it against this virus by initiating a T lymphocyte response. That is CD8 positive T cells. This is going to be one of your UWorld MCQ. Is that clear?
Yes,
Hello?
sir.
Okay,
Can you
perfect.
repeat this concept, please?
Okay, we discussed that EBV is going to, attack on three things, right? It's going to attack three things: your B cells, your oropharynx, and liver cells macrophages. Right? Just write it down on your first aid book. It's going to attack three like cells: B cells, your oropharynx mucosal cell, and your macrophages, right? But we already know as a general concept, whenever we have a viral infection, T cells are going to come, they're going to attach, if you guys remember, MSC1 and destroy all of the cells, cytotoxic T cells. Is that clear now?
Yes, yes.
We did this in immunology, if you guys remember. Hello?
Yes, correct, sir.
Okay, okay. So based on these things, let's discuss what would be the presenting features, right? If I have, okay, can I say that whenever we have whenever we have a cytomegalovirus or EBV infection, T cells are going to grow. You are going to see a lot of T cells. So from where do T cells come? We already know immunology, paracortex. Remember?
Yes.
Yes,
So again, your next MCQ, which which part of your lymph node is going to undergo hyperplasia? What's that?
paracortex.
Paracortex. Perfect. So if the paracortex is becoming hyperplastic, so can I say that an entire lymph node is going to appear big? A big lymph node, because the
Yes.
paracortical area is enlarging. So can I say that we are going to have generalized lymphadenopathy, especially cervical lymphadenopathy?
Yeah. Excuse me, is it called the Downy cells? Enlarged lymphocytes?
Enlarged what?
Downy cells? Is it Downy cells?
Downy cells. I don't have idea of that, but you can just search, right? But the idea is that the T cells or the paracortical area is going to enlarge, right? That's the MCU which you are guys are going to see. Like the term which you use, like, to be honest, I am not aware of that. But you won't see this in anywhere, right? In the U word or in your NBMEs, right? Is that clear? Hello.
Yeah.
Yes, sir.
Thank you.
Okay, thank you. Right. So your next MCQ is that a T cells is going to become hyper. They're like the paracortex is going to become hyperplastic, so it would appear in the form of lymphadenopathy. And we already discussed in the spleen anatomy, if you guys remember, right? We have an arteriole, remember, and surrounding that arteriole, periarterial sheath, T cells were sitting there, right? Hello.
In the
Did you guys-
spleen.
Yes, in the spleen. Did you guys remember that?
Yeah. Yep.
So
Yep.
can I
Yes.
say that this area again is going to become hyperplastic because in order to fight off a viral infection, so can I say that it would appear in the form of splenomegaly?
Yes.
Yes.
Perfect. So you are going to see splenomegaly, one of your word MCQ. Those individuals who are having this kind like infectious mononucleosis, they should avoid contact sports. Your exact word MCQ. Why? Because they have splenomegaly, and if they are doing some contact sports, so for example, if unfortunately they have a hit on their spleen, so spleen can rupture because already it's big, it's enlarged, so there is increased chances of rupture. Is that clear?
Yep.
Okay, perfect. Okay, so the test basically used for infection with EBV virus is monosport test. So what is monosport test?
Doctor, can you please explain about the splenomegaly?
Okay, no problem. So we already know that it's a viral infection, and T cells basically fights off your viruses. Is that clear? T cells, T lymphocyte, especially the cytotoxic CD8 positive T cells. We discussed each and everything in immunology module. Did you guys remember that?
Yes. And
Oh,
around the perisplenic venules, there will be T lymphocytes which will be activated with viral infection. They will go under a hyperplasia. After that, the spleen will be enlarged and it will be fragile with the contact sport.
perfect. That's perfect, right? So if we need a lot of T cells, it means the respective areas where T cells are made, they should undergo hyperplasia. Where are T cells present? In the lymph nodes and periarterial sheath within the spleen. Once it's enlarged, it's going to appear as splenomegaly. Is that clear?
Yes, doc, it's clear.
Okay. But another thing which you guys should just keep in mind, basically we undergo a test which is known as monosport test for screening. What is monosport test? In this individual, he'll be just making antibodies again. Okay, he'll be having heterophile antibodies. What do we mean by heterophile antibodies? he will be making antibodies against horse or sheep antigen or blood, right? Or the red blood cells. Okay, so this guy basically is gonna make antibodies, especially IgM antibodies against horse and sheep red blood cells. Why? How to remember this point? Why do we have antibodies against horse and sheep? The idea is really simple. You can simply think of for your concept. If it's attacking your B cells, right? You know, the EBV is gonna attack your B cells. Is that clear?
Yes.
Okay, and B cells in turn make your antibodies, right? Once it invades B cells, it would cause disruption. You know, a B cell is going to be like mad. You won't know what should I make, right? Because everything is disrupted. You know, if we have just took over the cell, so it would just become mad and producing a lot of antibodies, which he himself don't know. But in that antibodies, you will be seeing some antibodies against horse and sheep red blood cells. Is that clear? It's so simple.
Yes, doc.
Okay, so you are going to see you will MCQ on that as well. They'll simply tell you we have an individual, we have antibodies against horse and sheep. So what do you think? So for remembering, so just think of EBV have took over the B cell. B cell is now mad. It's just making stuff which we do not need, right? Especially antibodies against horse and sheep red blood cells. Is that clear?
Okay, got it.
And definitive diagnosis, just look for EBV viral capsid. It's going to confirm that yes, we have this bug on this virus going inside, like growing inside your body. That's all. Is that clear?
Yes,
Hello?
doc. So yeah,
Okay.
there will be monospot test positive.
Yes, but positive monospot test, it can also be negative. But remember, whenever we have negative monospot test, it do not rule out the disease. CMV, if we have, infectious mononucleosis, like due to CMV virus, like CMV can have negative monospot test, but still you cannot rule out simply by looking for the monospot test. The definitive diagnosis is look for viral capsid. But if the monospot test is negative, it might be due to CMV. Is that clear?
Yeah.
So negative monospot test it's for screening purposes. It's not for definitive diagnosis. For definitive diagnosis, you should look for the viral capsid, or else you should just confirm the virus whether it's going there or not. Is that clear?
Yeah. Clear, doc.
Okay, perfect. So now we are going to do the toughest topic for students, acute leukemias, right? And believe me, once we did this lecture, you will be just master with leukemias. But before that, I want you to have your notebook and pencil. Just go grab your pencil and your notebook. Then I'm going to start the lecture, right? And you guys have to note down because I'm going to explain it in a form of table, right? I'll be making my own table. Just write it down, and before your exam day, just look for that table, and you won't miss a single MCQ. Is that clear? Just I'm waiting for you guys for 2 to 3 minutes. Just grab your pencil and paper and just come. Is that clear? Hello?
Yes, sir.
Okay.
Yes,
So
doc.
please, yes, please, just go and grab your pencil and paper, and whatever I'm drawing, just note it down. You should be having a big page, right? Because this table is going to extend even like it's going to be a big table.
Doctor, can you just repeat what you said about the monospot test?
Okay, so for the monospot test, we discuss what happens in this test. Your body, for example, if I'm, God forbid, if I have, EBV infection, right? So my B cells are gonna make antibodies against horse and sheep red blood cells. How? Why? Because your EBV is going to attack your B cells. We already discussed it here, right?
Yes.
CD21, and B cell is going to be mad because it's took over, like the B cell if is took over by EBV, so it would be just making things random kind of things. So in that random kind of things or antibodies, you will be seeing some antibodies against horse and sheep red blood cell as well. Simple.
Okay. And it's a screening test, right?
It's a screening test. It's not for the definitive diagnosis. You have to look for the viral capsid, right?
Okay. Got it.
Okay, so I'll be starting you within 1 minute. I'm just waiting for you guys to grab your pen and paper. Okay, so 1 minute remaining. Are you guys here? Hello?
Yes.
Yes, we are here.
Okay, so let me just start. Before starting leukemias, we are going to make a table which we already are familiar of, right? So we have hematopoietic stem cell, that is CD34, right? Okay, we have two lineages, if you guys remember, right? Yes. So Dr. Ramesh is going to help me with that. Myeloid lineage, right? And we
Yes.
have our lymphoid lineage, right?
Lymphoid. Yes.
Okay. From the myeloid lineage coming down, we have,
Erythroid.
okay, let me just draw it. The first we have erythroblasts.
Erythroblasts.
Erythroblast,
Blast.
and from the erythroblast we are going to, okay, it's a blast are basically immature cells. You already know that we use the term blast for immature cells, right?
Mm-hmm.
Then we
Yes.
have red blood cells are going to arise from erythroblast, right? Then we have myeloblast,
Megakaryocyte.
right?
Okay.
Myeloblast,
Blasts.
immature. Then myeloblasts are going to give us granulocytes, neutrophils, basophils, and eosinophils. Is that
Yeah.
right? Then we
Yes.
have
Megakaryoblast.
monoblast, right?
Okay. Okay. Yeah.
Yes, from the monoblast we are going to have monocytes, and monocytes further are going to mature into macrophages, right?
Yes.
Okay. Then we have megakaryoblast. Blast. After megakaryoblast, we are going to have megakaryocytes and platelets, right?
Yes.
Okay, perfect. So have you guys just write down this table? Hello?
No, sir. No, sir. 1 second, please.
Okay, just write down this table, right? Shall I just go for the next lineage?
1 second, please. 1 second.
Okay. We are going to spend some time on these leukemias, but believe me, in the end of this lecture, everything is going to be so simple, so understandable. Believe me. Just follow me and just follow this pattern.
Excuse me, sir. We cannot read, like the myeloblast, and then what's the next myeloblast, and then going down.
Okay, you have megakaryocytes and your platelets. Okay.
No, I mean the first one is erythroblast.
Erythroblast, it's going to mature into red blood cells. Myeloblast, it's going to mature into neutrophils, basophils, and eosinophils. Monoblast, it's going to mature into monocytes and macrophages. Megakaryoblast into megakaryocytes and platelets. Is that clear?
Yes.
Okay.
Sir, megakaryocytes are coming from megakaryoplasts or
Yes.
megablast?
Megakaryoblast. Right?
Okay, thank you.
Blast into sites into platelets. Simple. So let me just draw down this lineage. You guys should just write it down on a big paper, but I do not have space. So I'll just draw down here, right? The next lineage, that is lymphoid lineage. From the lymphoid lineage, we know there comes B cells and T cells. But before B cells, B lymphoblast, right? From B lymphoblast, we have naive B cells. What are naive B cells? Those B cells which are inactive. If you guys remember, sitting in the primary follicle, right? Not exposed to any antigen. From that, Once they are mature, they are going to convert into plasma cells. You already know that, right? And we have T lymphoblast. Right? From the T lymphoblast, again we have naive T cells, inactive one, aren't exposed to any antigen. Then we have CD8 positive T cells and CD4 positive T cells. Is that clear? Have you guys noted down? Hello?
Yes.
Okay.
Yes.
Okay. So let's discuss what is acute leukemia, right? Acute leukemia. Right? Whenever you see leukemia, so what does it like indicates that you are going to have cancers of your leukocytes or cancers of your all of these
Sir,
lineages
can
which,
you show the this line for a second?
sorry.
Please continue.
Okay, so leukemia is basically neoplastic proliferation, right? Neoplastic proliferation of the cells which we discussed. Whenever you see the term acute basically means that you will be having neoplastic proliferation of immature cells. Immature cells. And we know what are immature cells? The blast cells, right? And whenever you see chronic leukemia, basically you have neoplastic or cancerous proliferation of mature cells of the above lineage. Is that clear? Acute leukemia and chronic. Whenever you see the term acute, it means you are going to have leukemia or neoplastic proliferation of immature cells or blasts. Whenever you see the term chronic leukemia, it means that you are going to have neoplastic proliferation of the mature cells. We are going to discuss each one. Is that clear? Hello?
Yes, clear, doc.
Okay, let's just continue this discussion. Okay, so we discuss whenever you have neoplastic proliferation, but we have a standard number for that. Whenever it's greater than 20%, whenever we have greater than 20% of these blast cells, then we are going to call it acute leukemia. Is that clear? It's a standard number or a standard along which we are going to confirm whether it's a acute leukemia or not. Is that clear?
Yes.
Okay. So the problem with accumulation of these blast cells, blast cells are immature cells. We do not need some immature people. We do not need some immature cells because they are of no use. We need mature red blood cells. We need mature platelets. Is that clear? But if you have a lot of immature cells within the bone marrow, right? Hematopoietic stem cells come within the bone marrow. So can I say that now these mature people have, took over a lot of place and there's so less place for the mature people, for the mature lineage. So what happens? It's going to end into a condition, pancytopenia. Is that clear? Hello?
Yes.
Okay. So,
No, sir. Sorry, I did not understand.
okay, so the point is that we are having neoplastic proliferation of immature cells, right? Immature cells or the blast cells are of no use, right? You need mature cells, right? So if you have an extra proliferation or cancerous proliferation greater than 20% of these immature blast cells, so it's going to occupy a lot of space within your bone marrow. So you have less space for the mature cells, or in other words, I would say that the mature cells are less, all of these mature cells, you can see, like all of them are immature cells. So whenever we have greater than 20%, greater than 20%, greater than 20%, or leukemia, acute leukemia. So what happens for the mature cell? The space is very low. So all of the red blood cells is going to go down. The platelets lineage is going to go down. So it would lead into a condition, pancytopenia. Everything goes down, right?
So I
Okay.
want to ask you a
Thank you.
question.
Thank you.
In this
Yes,
acute
please.
leukemia, are we talking about all the blast cells or just for the leukocytes blast?
Okay, wait. Let me just all the blasts, right? All the blasts. It's a generalized term used for all of the blast cells, right? Immature, right?
Okay.
I'm going to discuss each one in detail. Don't worry. But if we have any blast cell lineage, it's going to compromise all of the mature cells because they are occupying a lot of space. Is that
Yes.
clear?
Yes.
Okay. So now let's come to your question.
Excuse me, sir.
Yes, please.
All mature cells, you mean these 4 cells, yeah?
Okay. Listen. We discussed their immature blasts are immature. erythroblasts are immature, monoblasts are immature, myeloblasts are immature, megakaryoplasts are immature. On the other hand, lymphoblasts are immature, and T lymphocyte blasts are immature. I'm talking about all of the blasts, even in your myeloid lineage or lymphoid lineage. Is that clear?
Yes, yes, I got. Thank you.
Okay, it's a generalized thing which I'm discussing, right? Okay, so let's be a little bit specific. We discuss a generalized concept whenever we have increased blasts, but we know that blasts can be of or either of myeloid lineage or lymphoid lineage, right? Hello?
Yes, sir.
Right.
Like we can have, acute leukemia of these blasts, acute leukemia, of this blast, and acute leukemia of the T cells. So now let's differentiate the acute leukemias from of like both of these lineages. So acute leukemia or increase than 20% of blast cell, whenever it happens in this lineage, we are going to call it as acute. Yes,
Myeloid.
myelogenous leukemia, because myelogenous here stands that the blast or the neoplastic proliferation of the blast which we are discussing is derived of myeloid lineage. Is that clear? Hello?
Yes, sir.
Yes.
Clear.
Okay. But we also have blast in the lymphoid lineage, right? So what should be I calling if we have the greater than 20% blast in the lymphoid lineage? So the word or the term used for that is acute. Can you just,
Lymphoblast.
Dr. Najia, fix your mic? I'm just hearing my voice again. It's kind of disturbing me. Hello? Okay. So if we, Dr. Nazia, can you just please fix your mic? Oh, thank you. So if we have, like greater than 20% blast in this lymphoid lineage, we are going to call it as ALL, acute lymphoblastic leukemia. Is that clear?
Yes.
Simple. So we have AML and ALL. What is AML? Whenever we have greater than 20% of blast, we're in the myeloid lineage here, which we discuss. Either this, either this, either this, or this. We are going to call it as AML, right? And whenever we have neoplastic proliferation greater than 20% of blast at lymphoid lineage, either B lymphoblast or T lymphoblast, I'm going to call it as acute lymphoblastic leukemia. Is that clear?
Yes, clear.
Okay, perfect. But now a question arises that how to differentiate both of these leukemias? How to differentiate leukemias of your myeloid lineage or lymphoid lineage? So remember, whenever we have leukemia of myeloid lineage, we will be discussing in a little bit detail, but it's like a generalized thing which I'm discussing. They'll be having in their blast cells, they'll be having something which is known as, yes, myeloperoxidase. Remember what is myeloperoxidase? You guys already know that.
Yes.
Yes. Remember the MCQ which we discussed in pulmonary. Myeloperoxidase is going to fight off the infection, giving green color to your sputum, your UL MCQ. Remember?
Yes, doctor.
Okay. Are you guys able to understand? Hello?
Yes, sir.
Yes.
Okay. Okay. So we already know that we are going to have like myeloperoxidase here. But remember, as it is a cancerous or neoplastic phenomena going on, right? So this myeloperoxidase is going to precipitate as a crystals, right? So you're going to see a crystal or a rod shape, and that rod shape is basically going to be a precipitated or concentrated form of this myeloperoxidase. Is that clear? In the cancerous cells. Hello? Hello?
Yes,
Does
sir.
it have any name or just as precipitated crystals?
Okay,
Rods.
listen,
Yeah.
it's known as ore rods.
Oh, okay.
Yes. Okay. What's the problem with ore rods? If you guys remember in DIC, I was just talking that I'm going to discuss something in the future. You guys should be aware of that. If these ore rods came out in your blood, it can cause DIC. Remember, you have a UL MCQ on that. I just told you guys I'm just leaving one of the cause of DIC, which I'm going to discuss in future lectures. This was the best place to discuss, right? Again, we have AML. It's a neoplastic proliferation of the blast cells. It's a cancer, so the myeloperoxidase is specific for AML, and as it is cancerous, you can have precipitated form of myeloperoxidase. It would appear in the form of ore rods. If the ore rods leak out of the blastic or neoplastic cells, It can cause DIC. Is that clear?
Clear.
Yes.
Okay.
Okay.
So if myeloperoxidase is specific for AML, then there should be something specific for ALL as well, right? What's that? That's TDT. What's TDT? It's a, yes, what is TDT?
It's a tumor. It's a marker which is start with the native T cells and yeah, in the bone marrow.
Okay, simply it's a DNA polymerase, it's a DNA
Yes.
polymerase. But we are specifically going to see TDT in ALL or lymphoblastic lineage. The idea is really simple. Why? Because we have B cells here, right? In this lineage, we have B cells. And if you guys remember, B cell was undergoing a somatic hypermutation. So it requires a lot of DNA polymerase activity. Is that clear? So TDT is specific for ALL, this lineage. Is that clear? Are you guys writing, noting it down? Hello?
Sir,
Yes, sir.
what have you written? DNA polymerase B cell?
Okay, TDT is basically a DNA polymerase, right?
Yeah.
How to remember that DNA polymerase is like, specific for T lymphoblast? Because we need a lot of DNA polymerase activity in B cells and T cells, right? Because B cells have to make a lot of different combinations of your antibodies, and different combination requires, a lot of, genetic involvement, genes involvement. So we require DNA polymerase activity there, right? So TDT is going to be, that's why TDT is going to be specific for lymphoblastic lineage. Is that clear? This is
Yeah.
the reason, or this is the cause, or this is like how can you remember it? Simple.
And
Is that
TDT
clear?
found in ALL just, yes?
Yes, in the ALL lineage, not in AML, right? So myeloperoxidase, okay. So you have a UWorld MCQ. They are going to tell you we have a blast. We have a blast. So question should arise in your mind. We have two lineages. This blast can be of, lymphoid lineage or myeloid lineage. How to differentiate? If they tell you they have all rods of myeloperoxidase, your answer should be AML. If they tell you that they have TDT, your answer should be ALL. And
ALL.
these, and you have these two MCQs in your UWorld. Believe me, you are going to see these two MCQs, right?
Please, could you come again with the differentiation, please?
Dr. Ahmed, please, are we recording this section?
Yes, I'm just recording it. Is that clear? Are you guys writing it down?
Yeah, can you please just quickly?
Okay, please raise your hands. If you guys have any doubts, please raise your hand. Yes, Dr. Satrov. Yes.
About the differentiation, last topic, can you please quickly repeat, please?
Okay, no problem. We discussed we have myeloperoxidase and AML lineage, right? Because how to remember that? How to memorize it? Because it have like myeloperoxidase is highly specific for neutrophils or macrophages activity, right? In order to fight off an infection. You already knew that once we were doing pulmonary section, right? So it should be obvious that myeloperoxidase would be specifically present in myeloid lineage, because from the myeloid lineage you get neutrophils and macrophages, right? So it's myeloperoxidase is highly specific or a marker for AML. It's a marker, right? In order to look whether this blast is coming from myeloid lineage or lymphoid lineage. If in the question stem they have mentioned that they have myeloperoxidase, just think of they are talking about leukemia of myeloid lineage or AML. If they mention we have TDT, so just think of that we have leukemia of your lymphoid lineage. Is that clear?
Yep.
Yeah.
I can help, Doc. Yeah. M in acute myeloid leukemia will remind us of myeloperoxidase. M and M. Okay, guys.
Okay.
Mm-hmm.
Okay. So let's continue our discussion further, right? We discussed we have ALL and we have AML, right? But now question arises that if we have ALL can still be of two types. Either you can have B lymphoblast greater than 20%, or either you can have T lymphoblast greater than 20%, which confirms our definition of acute leukemia. Is my question correct? Can I just ask that question to my brain?
Yes.
Yes.
Okay. Okay, perfect. So now we have to look whether these blasts are coming from the B or from the T cells, right? So those blasts, if you have greater than 20% blasts, that are basically your B lymphoblasts. So we are going to use a term that is known as B. Yes, ALL. Is that clear?
Yes.
Yes,
But
Doc.
if we have greater than 20% blasts, which are basically T cells, we are going to use the term T ALL. It's so simple, right?
Yes.
Okay, BALL. And okay, how do I know that it's a BALL or it's a TLL? You guys already know that you are going to look for the surface markers. The
Yes.
less surface marker 2, 6, 8 basically indicates T, and the greater surface markers we discuss each and everything in detail. We are just building some more concepts on the things which we already discussed. On BALL, you're going to see surface marker like CD20, 21, the higher markers. Is that clear? So this should be your differentiating feature. How should I know it's BLL? How should I know the TL? Just look for the surface marker. 20, 21, 6, 8, small numbers, right?
Yes.
Okay. So this was all about your BALL and TALL. So you should look for the surface markers, right? Now let's come to the blast or the acute leukemia on the other hand, on this chart, right? So, hello, are you guys just following me?
Yes, Doc. We are with
Yes.
you.
Okay. We already discussed that we can have like a neoplastic proliferation. It's going to have myeloperoxidase, MPO, or rods, precipitated form, aggregated crystals. Is that clear? So let's take our discussion further. We can have blasts here, right? We can have like greater than 20% of blasts, but their parent or the father can be blast. Is that clear? So what should be the term or the name which I'll be using for the blasts which are coming from the lymphoblast? Are you guys able to understand? Like for here, if it's coming from B, I'll just call it simply BALL and TLL. What about myeloblast? I'm going to call it as acute promyelocytic leukemia. What? Acute promyelocytic leukemia. Are you guys able to understand? Because you have acute, greater than 20% blast, myelocytic, the myeloblast one, right? And leukemia, greater than 20% of blast. Is that clear? Or neoplastic proliferation?
Yes.
Okay. So let's discuss acute promyelocytic leukemia in a little bit more detail. Why do we have that? What's the reason? What's the cause of having that? So, an important MCQ you are going to see this in your JUVET as well. Basically, how do we get acute promyelocytic leukemia? Till now, I think all of the concepts should be clear, right? Hello?
Yes, Doc. Clear.
Yes, sir.
Okay. So now let's discuss it in a little bit more detail. What happens that you have 15 and 17 translocation, right? What do we mean by 15 and 17 translocation? Let me just make this concept as easier as a piece of cake, right? Normally, you have a 17, simply you can think of, right? For your memory or for your, I'm just making this. So, you know that on the 17 chromosome, basically you have something which is known as retinoic acid receptor, right? Hello? And this retinoic acid receptor, a retinoic acid bind to this receptor, it would lead to maturation of your myeloblast, right? Then it's going to convert into neutrophils, basophils, and eosinophils, right? Hello?
Okay, Doc. We are following. Yeah.
Okay. But what's translocation? Whenever the 15 comes here, and the translocation, basically the idea is that, for example, if this is your chromosome and you have certain genes for retinoic acid receptor, we already know, which is important for the maturation, right? What's the basic idea of translocation? Something from the 15 chromosome is going to come, it's going to attach, or it's going to adhere here, and once it, like, this chromosome is replicating for itself, it's also replicating the genes which have come from 15 chromosome. This is the idea of translocation. Is that clear? Hello?
Yes, Doc.
Okay. So when certain genes or certain genes comes from the 15 chromosome, so it would disrupt this normal mechanism, right? This was a normal mechanism. 17 was basically encoding for your retinoic acid receptor because it's important for maturation. If something else, some foreign thing is coming, it's attaching. So can I say that now this normal process is going to be disrupted?
Yes.
If the normal process is disrupted, what was the normal process? Maturation. So now you won't see any maturation. If you aren't seeing maturation, simply you are going to have a lot of blasts. If you have a lot of blasts, we just call it as acute promyelocytic leukemia. So simple.
Yep.
Is that clear?
Doctor, this
Yeah.
the 15, what you said, what this 15 gonna do? Please repeat it.
Okay, okay. So normally, what's the normally we discuss what is the goal of chromosome number 17. On chromosome number 17, you have genes which basically encode for retinoic acid receptor, right?
Yes,
Hello?
right.
Okay. And what retinoic acid receptor do? It leads to maturation of your
You,
myeloblast, right?
yes.
Okay.
Yes.
If now something is coming from, okay, something, I'll just use the term something, but it's not like a normal thing, right? If something is coming from, 15 chromosome, or if some genes are coming from 15 chromosome, they are, interfering the normal activity. What you 15 chromosome genes are going to do? They are going to interfere, the normal activity of your retinoic acid receptor. So now the maturation won't happen. Is that clear?
Yes.
If the maturation do not happen, so we are going to have a lot of blast that is greater than 20%. And whenever we have greater than 20% blast, we call it as leukemia, acute leukemia, and in this case acute promyelocytic leukemia. Is that clear?
Yes, clear.
And you are going to see MPO there. You already know that. Is that clear?
Yes.
Okay, so let's have 5 minutes of break. I think I also have to, drink a cup of water, and we'll be discussing. So till now, are you guys just getting the leukemias?
Yes, we are good. Thank you, Doc.
Okay, thank you so much. So let's have 5 minutes of break, and let's continue our discussion further. You guys can just, do a revision with yourself. Dr. Amis, you can just, kind of do revision. I'll just be back in like 5 minutes.
Okay.
Hello, anyone can help with what was I missed a thing like acute promyelocytic leukemia. I understood the chromosome 17 thing, but how acute promyelocytic leukemia, sir, did sir say anything?
Okay, so acute promyelocytic leukemia is like when there is, see, myeloid lineage gives rise to erythroblast, myeloblast, monoblast, and megakaryoblast.
Megakaryoblast.
These all four types of blasts. Okay, so any specific type of blast, if it is greater than 20%, then it will fall under the category of AML, acute
Yes,
myelogenous leukemia.
leukemia.
Now, depending upon the out of four categories of the blast, which specific blast is more, or which specific blast is causing the problem, we can divide AML into different subtypes. So when myeloblasts is more than 20%, then that variant of AML is called APML. So that is acute promyelocytic leukemia. Now, specifically about APML, it is caused by 1517 translocation, where the normal function is like 17 chromosome has genes that codes for RAR, retinoic acid receptor, which helps in the maturation of myeloblast into different the neutrophils, basophils, and eosinophils. But some genes from 15 chromosome comes in and binds with the 17th chromosome. You can like you think like it's knocks off the functional portions, and it just like replace it with defective genes, and thus it interferes with the proper coding for RAR, that is retinoic acid receptor, and which is needed for the maturation of the myeloblasts. So that is not happening properly, and then we will see APML. And APML, since it is AML by basically, so we will all will find all rods there.
Yes, Dr. Ramiz, what you discussed in the start of the lecture, I can kind of like.
Thank you so much.
No, I think Dr. Devangsu was asking about APML. What was APML?
Yes.
What sir told about APML? So yeah, that was it.
Very good explanation, Dr. Ramis.
Thank you so much.
Thank
Excuse
you.
me. You mean APML, acute pro, yeah?
It is acute promyelocytic
Thank you.
leukemia. Yes.
Hello, are you guys here? Hello.
Yes, doctor.
Okay, okay. So let's discuss our other variants of myeloblast, right? So we can also have like greater than 20% of monoblast as well. That would also come under the category of AML. Can I say that?
Yes.
So what's
Yes.
the name used for that? That is acute monocytic leukemia. Acute monocytic leukemia, right? But in acute, okay, acute monocytic leukemia. But remember, in acute monocytic leukemia, you won't see any MPO. Really important. In myeloblast, you are going to see MPO, right? But in acute monoblast, if you have acute monocytic leukemia, you won't see MPO. And in case of megakaryoblast, right? What's going to be the name of leukemia of megakaryoblast? That is going to be called as acute megakaryoblast leukemia, right? Acute megakaryoblast leukemia. Is that clear?
Yep, doc.
Okay. Okay, just give me a second. Okay, so we are going to use the term acute, like okay. So it also won't be having MPO. You won't see any MPO in this. Why? The idea is really simple. Do immature monoblast, can immature monoblast kill your bacteria? Yes or no?
No.
If it cannot kill your bacteria, right? So it won't be having MPO. That's so simple. And the megakaryocyte, which is going to lead to formation of platelets, again, it have nothing to do with MPO because platelets do not fight off your bacteria. So again, it won't be having MPO. Is that clear?
Yes, clear.
Yes, doc.
Okay. Okay, just please give me 1 minute. I have problem with my MacBook. I think it's off. Just give me 1 minute. Okay, let me fix it.
Hello, can anyone repeat about the MPO part? Sorry, I missed that.
He said that for the acute monocytic leukemia, where we're gonna see monoblast, okay, more than 20%, there will be no MPO because they are immature and they cannot kill the bacteria, yeah. So there will be no MPO. And same he said for the acute megakaryoblast leukemia, where we're gonna see more than 20% of megakaryoblast. In this situation as well, there will be no MPO because platelets have nothing to do with the bacteria.
All right, thank you so much.
Okay.
So
Can you guys
sorry.
just hear me? Just sorry for some problems I'm facing. Really sorry for that. Okay, an important point which you guys should remember regarding your acute monocytic leukemia is that whenever you have like this condition, that is okay. What is acute monocytic leukemia? We already know that it's acute. It means the blasts are going to be more than 20%, right? Monocytic, the monoblasts are going to be more than 20%, right? It won't be having MPO. But remember, these neoplastic cells, acute monocytic leukemia, they love to infiltrate into your gums, right? They love to infiltrate your gums. So you'll be having like problems with gums, right? So this can be one thing which you can associate it with acute monoblastic leukemia, right? So these cells infiltrate gums, they can cause inflammation, right? Infiltrate your gums. Is that clear? Okay. So it was all about your the information which you need for the AML, right? So it was all. Let me just repeat it again one time, right? If you guys have any question, you guys can ask me, right? So we discussed we have two lineages, right? CD34 myeloid and then 4 lineage. Is that right? Hello?
Yes, right.
We discussed from the myeloid lineage, we have erythroblast, myeloblast, monoblast, megakaryoblast. And from the lymphoid lineage, we have B lymphoblast and T lymphoblast. We discussed here what is acute leukemia. Whenever you see the term acute, think of it's a neoplastic or a cancerous proliferation of your blasts, right? More than 20%. What's the problem if we have more than 20% of blasts? These immature people or these immature blasts are going to occupy a lot of space in your bone marrow and it would disturb the normal functioning or the normal mature cells, right? That's the problem, right? Which is going to lead to pancytopenia, right? Hello? Is that clear?
Yes, right.
Yes.
Okay. So the next question arises in our mind that we have blasts everywhere. We have blasts in lymphoid lineage, we have blasts in the myeloid lineage. So how to differentiate them? So to differentiate them, we basically use, okay, those blasts in the myeloid lineage which are greater than 20%, we are going to call it as AML. If you have more than 20% of blasts in the lymphoid lineage, we are going to call it as ALL. But the problem with that is how to differentiate whether it's blast coming from B cells or T cells. For that, we use the term BALL or TALL. You should just look for the surface markers, right? Hello?
Yes, doc.
Yes.
Okay, here we have blast from myeloblast. What term are we going to use? Acute pro-myelocytic leukemia. And what's the problem? 15-17 translocation. Normally, retinoic acid receptor lead to maturation. But if some genes are coming and interrupting this normal maturation, you are going to end into blasts. So that's going to lead into myeloblastic leukemia. Second, we have monoblastic leukemia, right? Monoblast, a lot of monoblast, no MPO because it cannot fight off infection. In this way, you can just remind it, right? And it loves to infiltrate gums. Megakaryoblast, no MPO because it have nothing to do with MPO. And again, it's going to be called as acute megakardioblastic leukemia. How to differentiate AML from ALL? If we have or rods or precipitated myeloperoxidase, right? It's going to tell us that we are dealing with acute myelocytic leukemia. If we have TDT, a DNA polymerase, it will just tell you we have ALL. Is that clear? That's so simple. Hello?
Yeah.
Can I just proceed further?
Sir,
Yes,
sorry to interrupt. I have one question. If
Yes,
we
please.
figure out that there is MPO, then only we can say that it is AML. So, but in monoblast and megakaryoplasts, there is no MPO.
Okay. So for that you have okay. That's a good question. For that you have to remind that majority of the cells come from myeloblastic, right? From this lineage, majority of the cells like neutrophils, basophils, and xenophils. A lot of cells come from myeloblastic, right? So they are abundant, right? And majority is the authority, right? So in majority of cases, you are going to see myeloperoxidase in your question stem. In majority of cases, you are going to diagnose it with that because you are going to follow the majority, right?
Yes.
Is that clear? But if you have question on monoblast, that would be giving you some extra information as well, like infiltration of gums, problems with platelets. Is that clear?
Yes, got it.
Okay.
Yeah, I have small question about the gum hypertrophy. What is the explanation for it in the monocytes?
Okay, so the simple explanation for that, like you won't be tested on the entire explanation, but the simple explanation in order to remind is that whenever you have a lot of monoblasts, so they love gums. They would just go and infiltrate gums and cause problem there in the gums, right? Simple.
Got it. Yeah.
Highly specific. Just write it down. Right? They love to infiltrate gums. So now let's discuss chronic leukemia. I think we have discussed acute, so chronic is going to be so much easy. Chronic leukemia. Again, we have leukemia. It's a neoplastic proliferation, a cancer, right? And chronic, we discussed, it's a cancer of your mature cells, not your blast, right? Hello?
Yes, right.
Yes,
Okay.
yeah.
But now the question arises that we have mature cells in both of the lineages, right? So if we have neoplastic proliferation of your mature cells in your lymphoid lineage, what name are we going to use for that? Chronic lymphocytic leukemia, right? Chronic lymphocytic leukemia. Okay, so what is chronic lymphocytic leukemia? You can have neoplastic proliferation of these mature cells. Both of them are mature, right? Hello?
Yes.
But the question arises if, okay, it's a generalized term used for both of, neoplastic proliferation of the mature cell, both B and T cells. But the next question should arise in mind that we have two kinds of mature cells. Here you can see. a plasma cell and naive B cells, right? You have B cells or T cells. If I just tell you we have CML, so the question which you guys should be asking of me that if it's CML, so can you just tell me if it's a B or it's a T cell, because we have both mature cells on both sides, right? Are you guys able to understand? Hello?
No,
Yes.
no. Can you repeat, please?
Okay. Okay. So CML or chronic myelocytic leukemia is a generalized term used for any leukemia of mature cells in lymphoid lineage. But further lymphoid lineage give rise to B cells and T cells. So the next question, for example, if I tell Dr. Satrov that I have chronic lymphocytic leukemia, so the next question you'll be asking me that from the lymphoid lineage we have B cells or T cells. Can you just tell me, is it a leukemia of B cells or T cells, right?
Yeah, right.
Yes, of course, sir.
Sorry?
That's correct.
Please raise your hand before asking a question. Yes, Dr. Shafiq, yes?
Yeah, yeah. You mean how we could differentiate them by the CD
Yes.
markers or what?
We are just discussing that how to differentiate, but I'm just asking that this question should hit your brain, right?
Okay, yeah. Okay, doc.
Okay. So again, what we are going to do? We are going to look for the surface markers, right? So surface markers are the best indicators to tell you whether it's B cells or T cells, right? Here you have surface marker CD20, but here we are going to like move from the generalized term. You are also going to have CD5, but for CD5 we discussed that you are going to see CD5 on T cells. Remember?
Yes, doc.
But now we are just moving away from that generalized concept. Are you guys able to understand?
Yes.
It's an exception. It's an exception to a general concept we made. Our concept generally was that whenever we have less number, that basically indicates your T cells. Whenever you have more numbers like 20, 21, basically that indicates your B cells. But here you have an exception. Whenever you have chronic leukemia of naive B cells, you are going to see CD5. So if this is an exception, it means this question is more likely to be tested on your exam day. Just write it down. Is that clear? Hello?
So can you please repeat what is the naive B cells and what you said?
Okay. Normally, we know what are your naive B cells. Naive B cells are kind of B cells which aren't exposed to an antigen, right? They won't be making antibodies. Then we have our plasma cells. Plasma are mature B cell, like a more mature form, right? They are also mature. Naive B cells are mature, right? But they are the more mature one, right? Because they are just making your antibodies. Naive B cells cannot make antibodies. Why? Because they aren't exposed to your antigen. Once naive B cells are exposed to antigen, it would just be converted into plasma cells, making a lot of antibodies. Is that clear?
Yeah.
Okay.
Thank you.
So if we have chronic myelogenous leukemia, how to look whether it's a leukemia of your B cells or T cells? You have to look for the surface marker. So the surface marker generally we discuss the lower number surface markers are for your T cells and the higher are for your B cells. But here is the exception. Whenever we have chronic myelogenous leukemia or cancerous proliferation of your like a mature naive B cells, you are going to see a surface marker CD5. That's an exception to a general concept. So write it down. You can see this MCQ on your exam day. Is that right? It's an
Right,
exception.
I got.
Did you guys get that?
Yeah. So
Okay,
is it
yes,
both?
Again, this concept, last concept.
Okay, so what's your question?
Can you repeat the last concept?
Can I help, doc?
Yes, please help me. I
Yeah,
need your
yeah,
help,
doc.
Shafiq.
Yeah, I'm just rephrasing what you are saying, doc. Yeah, now we know usually with the B cells it's big numbers, and with the T cells it's small numbers. But for the naive B cells, there will be a small exception that it's naive cells. So they are by mistake they are taking CD5. In addition to the normal markers, we know it's big for the B cells. That's it in the tumor because it's an abnormal condition. Is it clear now?
Is it clear now? Hello?
Yes.
Hello? Okay,
Yes, it's
okay.
clear now.
So we discussed,
So
okay.
doc,
Yes,
doc,
please.
so is it both CD5 positive and CD20 positive, or
Okay,
like
it can
only?
have both. Yes, it can co-express like CD5. Yes, it would be having both of these receptors, right? Okay. So let me discuss it. Okay, let me just give you a clear description of this pathology again. We discussed we have chronic, yes, lymphocytic leukemia, right? This chronic lymphocytic leukemia can either be of B cells, and it can either be of T cells. Is that clear?
Mm-hmm.
But we know that, okay, for chronic we mean mature, right? For acute we need, like, we just skip the blast. We already discussed that, right? Mature, right?
Yes.
Yes.
But another question should arise that B cells, the naive B cells, are also mature, and the plasma cells are also mature, right? So that they basically, like, pass through certain stages. Like, you can simply think of, if naive B cell is 25-year-old, the plasma is 60-year-old, right? So if you just compare both of them, still the plasma is more mature. Is that clear? Both of them are mature, but the plasma cells are more mature than your naive B cells. Is that clear?
Yes.
Okay. Are you guys able to, understand or not? Shall I just
Yes, sir.
repeat it? Okay, perfect. So let's discuss about naive B cells. Till it comes in chronic lymphocytic leukemia, but we are discussing chronic lymphocytic leukemia specifically of B cells, and to be more specific, of naive B cells. Is that clear?
Yes, clear.
Okay. So the chronic myelogenous leukemia, okay, first of all, let's discuss what presenting features are we going to see. The idea is really simple. If we have a loss of B cells, or a neoplastic proliferation of B cells, we are going to see lymphadenopathy. The idea is really clear. Why? Because B cells sit in your follicles. If you have neoplastic proliferation there in the follicles, your lymph nodes are going to enlarge. Can I say that? So we'll be seeing lymphadenopathy, right? We are going to see hypogammaglobulinemia. Why? Because it's neoplastic B cells. It can't make normal antibodies. So you are going to see hypogammaglobulinemia. If you have less immunoglobulins, can I say that this individual is prone to infections?
Yes.
Okay. Okay, if it's a neoplastic proliferation, it's a cancerous form, so it would be just making antibodies which are, not needed by my body. Like, you can have autoimmune antibodies. You can expect from these cells to make certain antibodies which can kill your own body, can cause autoimmune hemolytic anemia. Can I say that?
Yep.
Perfect. That's all perfect, right? So let's discuss a little bit about naive B cells. So for that, I have a kind of story for you guys, right? For naive B cells, which are 25-year-olds, mature but less mature, and for the plasma cell, or you can simply think of a more mature variant of B cells, right? So you guys already know, whenever we have immature people, how to fix them. Just slap them, right? Slap them on their face. If they're just doing some immature acts, what we do normally, we just slap them, right? Hello?
Yes, doctor.
Like, just if you have an immature guy, he's just doing some immature act, so just slap him on his face. So what we are going to do with this naive B cells, we are going to slap them against, a wall, right? We are going to put them on a wall and slap them, right? So what would happen? They will be converted into a smudge cells. And what is a smudge cell? Basically, you are just taking these immature cells, and you're hitting them with your hand, and they become smudged, right?
Yeah.
They become smashed. So smudge cell, whenever you see smudge cell, they are basically these neoplastic proliferative cells which are coming from naive B cells. Is that clear? So smudge cell, whenever they just mention the smudge cell, basically they are dealing with neoplastic proliferation, chronic myelogenous leukemia, which arises from naive B cells. Is that clear?
Yes.
Okay. So whenever you see smudge cells on blood smear, you can just look a picture of smudge cells. You know the exact pathology, what's happening. You know everything about that. Is that clear? You know that it's a CML. You know that in the CML it's of naive B cells. You already know you're going to see hyperglobulinemia. You're going to see autoimmune hemolytic anemia, right? In the question, Sam, you're going to see lymphadenopathy. Why? Because they are a little bit immature, and we have slapped them. We slap immature people, right? Whenever they are doing some immature things. Is that clear?
Yes. And
Okay.
it's a chronic lymphocytic leukemia.
Yes. Is that
Just
clear?
Yes.
Okay. Plasma cells, simply you can think of, they are a little bit more mature, right? Hello?
Yes.
And what mature people do, they trap people. They can trap people. Right?
Yes.
Because they know everything, everything how to trap someone, right? Because they are mature. And, for the maturity for man, hairs are sign of maturity, right? Hairs. Whenever you see a
Yes.
hairy guy, you would say that he's more mature, right? So for the mature or the plasma cells, we are going to use a term that is hairy cell leukemia. Is that clear? We won't
Yes.
use the term plasma cell leukemia. We will be using a term hairy cell leukemia. Is that clear? Because he's a little bit more mature, having a lot of hairs, and he can trap people. Is that clear?
Yes.
Okay. So neoplastic proliferation of mature B cells, you are going to see hairy cells because these cells you are clearly going to see some hairs on the cell, right? Remember, for the immature, we just slap them. We just smash them. We just made a smudge cell out of that. But for a little bit more mature, they are hairy. They can trap people. What do I mean by trap people? Trap. For the trap, you should know that these cells are positive for tartrate resistant acid phosphatase. One of your UWorld MCQ. You don't have to go into the details, but they are mature, hairy cell. They can trap people, right? So they'll be positive for tartrate resistant acid phosphatase. Is that clear? Hello?
Yes.
Okay. Else, you are going to see splenomegaly. Why? Because simply you can think of, they trap people. All of these neoplastic cells would be trapped within the spleen. So once they are trapped within the spleen is going to enlarge. Is that clear?
Yes.
Yes. Are you guys following me or no? Yes or no? We are almost done with the topics.
Yes,
Follow.
sir.
Yes.
Yes.
Okay. And what else? How to deal with these mature cells, these hairy cells, which are trapping things. What we are going to do, if you guys remember, we have an adenosine deaminase. Remember? We discussed what adenosine deaminase normally do. It removes the amine group of adenosine, which is toxic, right?
Yes.
Remember?
Yes.
Yes, correct.
So we are going to give them a drug that is known as, yes, what's the name of that? Cladribine, right? Cladribine. So what cladribine is going to do? It's going to inhibit this enzyme. If this enzyme is inhibited, now we are going to see adenosine with a lot of, nitro groups, which are toxic. So these toxic accumulation can kill these, this clever, hairy, mature cells, which are trapping things.
What is the name of the medicine? Can you write it down, Doc?
Okay, so the name is cladribine, right?
Yes. Okay.
Okay.
Doc,
So,
can you just repeat what you said about that ADA and cladribine?
okay. If you guys remember, we discussed a pathology. What was that? Severe combined
Immunodeficiency.
immunodeficiency. And one of the cause of severe combined immunodeficiency was whenever this enzyme wasn't functioning, right? So we discussed what's the main goal of this enzyme? Adenosine deaminase. Normally, it deaminates your adenosine. Why do we need deamination of adenosine? Because whenever adenosine is bound with some amine groups, they are toxic to the cells, right?
Yes.
The pathology which we discussed, SCID, it was due to deficiency of this enzyme, and this metabolite was basically killing your cell. But as you already discussed that pathology, so we can use that here. We can give some drug which can inhibit this enzyme, which in turn would kill your hairy cells, your hairy, clever, trapping cells. And it would just help with this cancer.
Yes.
Is that clear? So for now, it was all for today. We are just left with the lymphadenopathies. So these were the highest yield things. And believe me, after today's session, you won't get a single MCQ wrong on your UWorld, even on your exam day, right? So I'll be just continuing the lecture tomorrow. Tomorrow, we are also going to spend some more time, right? Because we have an important topics left. Okay. Yes, any questions?
So I have a question.
Yes, please.
In hairy cell leukemia, you mentioned that we're gonna have a splenomegaly. Is
Okay.
it gonna be the same if it is even if there is in night people also if there is proliferation?
Your
Even
voice
then
is
they should be.
muffling. I can't hear you well. Can you just please fix your mic?
Can you hear me now?
Yeah. I think maybe I understand the question. I can
Yes,
read.
yes. What's the question?
She is telling, okay, now in naive B cells, we will have generalized lymphadenopathy.
Okay.
But why in the plasma cells we will have splenomegaly, and which is not like the one the previous lymphadenopathy. It's more in-depth question. Yeah, I don't know.
Okay. So the question is that in the chronic or in the naive B cells like cancer or neoplastic, we are going to see lymphadenopathy, right? But in hairy, we aren't seeing lymphadenopathy. That's your question?
Yes, sir.
Okay. So the idea is really clear, right? Why are we going to see lymphadenopathy? Because like, in the lymph nodes, we have follicles. In the follicles sit your naive B cells in the primary follicles, remember? So simply you can think of that if we are having neoplastic proliferation, so the follicles or the primary follicles are going to enlarge, right? And
Yes.
once they are enlarged, they can cause lymphadenopathy. While on the other hand, here we are going to see splenomegaly. So in the spleen, we more focus on the T cells, periarteriolar sheath, right? Periarteriolar sheath have T cells, right? And they also have B cells as well, right?
Yes. And I think, Doc, because the plasma cell already in the circulation, so who will filter
Yes.
the circulation is the spleen. But the naive B cells still in the lymph nodes.
Yes, like the naive B cells sit in the lymph nodes, while the plasma cells can be, moving here and there. Yes, Dr. Shafiq. So in this way, but the best way to, remember this point is trapping, right? So things are trapped within the spleen, right? What are trapped within the spleen? These mature cells giving you splenomegaly. That would be the best thing. And just, I would say just don't go into each and every details. It's like more than enough for you, right? To remember the
Sorry,
trap.
doctor.
Yes.
Thank you.
In naive cells, you said T and B cells are different. Can you repeat about that concept? How different it is from the other neurology we know right now?
Your voice is too low. Can you just please repeat your question? Or if Dr.
Yeah.
Shafiq, no.
Yeah,
Yeah,
you
he's
said
asking why the naive B cells is different from the other cells. I
Okay,
think
so
he's speaking about CD5 marker.
okay, so the naive B cells is basically different than that of okay. How to differentiate? Okay, the first question is that, or I got your question. Okay, how to differentiate naive B cells from hairy cell leukemia, right? The main differentiating feature is the cell marker. If you see CD5 and CD20 in the question stem, it would be mentioned. You can think of they are dealing with the naive B cells. If you see TRAP, tartrate resistant acid phosphatase, you can think of the hairy people trapping hairy people trapping other individuals. Simple, right?
yeah,
Hello?
okay.
So this should be
Yeah,
one of the, okay, and what's the difference between naive B cells and, the hairy cell or the mature or like more mature? The main difference is we discuss the age. One have 25 years, other have 60 years of experience, right? If you just compare both of them, so the hairy cells are more mature, right? In this way, you can just think of and differentiate both of these diseases. Is that clear?
yeah,
And
okay.
naive B cells are basically the cells which aren't exposed to any antigen, so they do not have ability to make like antibodies. But if you are just disrupting their ability, if you have neoplastic, so as you know that naive B cell in future are going to convert into plasma cell, so you are going to see hypoglobulinemia and things like that. Is that clear?
Yeah, okay.
Okay. So with this, I think we should just end our today's session.
One question. Can I ask?
Yes, please. Yes, please.
Sir, when you said during differentiating majority in CLL, it's called chronic myelocytic leukemia. But when you,
CLL is chronic lymphocytic leukemia. What's your question?
my question is like you wrote CLL, but while speaking, you told like majority of a lymphoid cell is known like chronic lymphoid lineage is termed as chronic myelocytic leukemia. So I got confused. Is it
When did
CML
I
or
say that?
CLL?
When did I say CML? I think
No,
I
I
said.
guess he just said that by mistake, but CML is myeloid and CLL is
Okay,
lymphoid.
where did I wrote it? Maybe it's by
No, you
mistake.
wrote CLL. You wrote CLL. So I just wanted to ask, is it just my hearing mistake?
Okay, where did I wrote CLL?
In lymphoid lineage, you wrote CLL, like chronic
So
lymphocytic leukemia.
okay, so it is a CLL, right? Because we are dealing with the lymphocytes.
So wherever we hear myelocytic, it's myeloid lympho.
Yes, whenever you
Right?
see CML, it's myeloid lineage, right? Whenever you see CLL, it's lymphocytic. It deals with.
Lymphocytic.
Is that clear?
Okay, clear. Thank you so much.
Okay, so before leaving, I want someone to revise, right? So let's have a quick revision because I guess that it's like confusing, but at the same time, very important. So I'll be just picking some random people, and you guys are going to tell me, right? So I think like we just spent a lot of time. So let me just pick someone for the discussion. Before that, okay, wait. So Dr. Ramiz is going to tell us both of the lineages.
Okay. So first of all, there is like the hematopoietic stem cells, that is the CD34 positive, and then from that we get two lineages, that is the myeloid lineage and the lymphoid lineage. Myeloid lineage gives rise to like erythroblast, which gives rise to RBCs. Myeloblast, that gives rise to neutrophil, basophil, and eosinophil. Monoblast, that gives rise to monocytes, and that whenever they migrate to peripheral tissue, it becomes macrophages. And megakaryoblast, which gives rise to megakaryocytes, and which ultimately gives rise to platelets. And talking about the lymphoid lineage, there is like the B lymphoblast and the T lymphoblast, and both of them give rise to naive B and T cells. Now, naive B cells differentiate into plasma cells at the secondary follicles. Naive B cells sit in the primary follicles, and the plasma cells they are converted into plasma cells, secondary follicles.
Okay, perfect. So, Dr. Tarun, can you just please tell us what is acute leukemia?
Yes, sir. So acute leukemia is basically there'll be proliferation of all the immature cells.
Okay.
So the percentage is more than 20% of the immature cells.
And what's the problem with that?
So when there's more than 20% of the immature cells, there'll be a decrease in all the mature cells. So it will represent a pancytopenia. There'll be decrease of all the erythrocytes, the platelets, and the neutrophils.
Okay, but if you just told us that we have acute leukemia, so my question is that we have blasts in both lineages. We have blasts in myeloid lineage as well as lymphoid lineage, right? So my first question is how to differentiate the blast from myeloid lineage and lymphoid lineage, and what are going to be the name which we will be giving to the respective like blasts?
Okay, so for the myeloid lineage, it's called the acute myeloid leukemia,
And for the
which
lymphoid?
is the lymphoid is going to be the acute lymphoblastic leukemia.
Okay, let me just ask you another question. So you just tell me we have AML and ALL, right? How to differentiate whether it's an AML or ALL with the majority? Yes.
AML, you're going to have positive OR rods. OR rods are basically crystal
Wait.
formation.
Or roads for
Yes,
ALL or AML?
AML.
AML, perfect, right. And what
Acute
are OR
myeloid
rods?
leukemia.
What are OR
OR
rods?
rods are crystals of myeloperoxidase.
Can they cause DIC when leaks to your blood? Can they activate your
Yes, sir.
coagulation test? Okay, you have a UL MCQ on
Yes.
it. Perfect, right? And you also have a UL MCQ on myeloblast, right? The OR rods, right? Okay, listen, in UL you are going to see another thing. They're going to give you a picture and you're going to see a small blue kind of crystal, right? A rod kind of thing. So just also go for the rod, the crystal, the needle shape, right? It's basically your OR rod. You have an MCQ on that as well. Is that clear?
Yes, sir.
Okay, so okay, my question is that if we have AML, so we have different blasts. We have like erythroblast, we have myeloblast, we have monoblast, we have megakaryoblast. So can you just please tell us something about that? Let's start with acute like monoblast. So what's the name used for that?
It's called acute monocytic leukemia. There'll be increased monoblast.
Acute monoblastic or acute promyelocytic leukemia?
For the monoblast, it's the monocytic leukemia.
Okay,
And
acute.
myeloblast is the promyelocytic leukemia.
Okay, for the myeloblast, it is acute promyelocytic leukemia, and for the monoblast, it's Acute monoblast. Okay, perfect. So can you just tell me something about acute promyelocytic leukemia?
Yes, sir. So this condition involves the 15-17 translocation.
What happened as a
So
result of that?
normally the chromosome 17 is the one that is gonna code for the retinoic acid receptor.
And
Okay,
what would
so
happen
when there is
if I have a proper retinoic acid receptor? What's the normal function of retinoic acid receptor?
that is the one for the maturation of the myeloblast.
Okay, perfect. If some genes are coming from the 15 and disrupting normal function of your chromosome 17, so can I say it would lead to like a failure of maturation or more blast?
Yes, increase of the myeloblast. The
Okay.
immature cells are gonna increase.
Okay, perfect. Okay, what else? What about monoblastic or monocytic leukemia?
The monocytic leukemia is the increase in the monoblasts.
Okay.
They are
What's special
usually
about that? Do they
characterized
have
by
MPO?
no, they lack MPO and there's gum infiltration.
Perfect. What about megakaryoblastic?
They also lack the MPO.
Okay, let's discuss blast of the lymphoid lineage. What's the name for that?
Of the lymphoid, it's the acute lymphoblastic leukemia.
Okay, perfect. So let's discuss. Okay, let's. Dr. Kenana, can you just please turn on your mic and let me just ask you some questions. Hello.
Yes, sir, I'm here.
Okay, so can you just tell me, like Dr. Tarun just said that we can have that's basically known as ALL, right? So my question is that we can have ALL of B cells or either of T cells because we already know the lineage. So how to differentiate whether it is a BALL or a TALL?
Okay, so in B cells, they're gonna be from like the markers. So B cells will have CD5 and CD20 together.
Hmm. I
So
think
this
that was for a chronic condition. I'm just discussing about acute. Acute condition do not have any exceptions.
Oh, sorry, I thought you're talking about the chronic ones.
I'm just ALL. I just mentioned ALL, acute lymphoblastic leukemia, BALL. Whenever you see acute, acute for blast.
Yeah, so they're gonna have the TTT marker, which will differentiate, which will say this is a lymphoblastic lineage.
Okay, okay. My
And
question is, if I want to differentiate BALL from TALL, how would I do that?
it's from the CD markers, like the lower numbers will be for
Perfect.
the T
That's
cells, and
perfect.
the higher numbers will be for the B cells.
Okay, that's perfect. Okay, so Dr. Muskan, are you here?
Yes, doctor.
Okay, can you just please tell us what is chronic leukemia? What's the definition which we built for
Yes.
chronic leukemia?
Okay, so we know leukemia is like the cancer, okay, and chronic in which there we're gonna see mature cells, okay. So it's like a
Okay.
picture of mature cells, and
Okay,
then
but we discussed that if okay, let's first of all discuss the chronic lymphocytic leukemia. That is the leukemia or mature cell cancer or neoplastic proliferation of your lymphoid lineage. But we have like two kind of mature cells. That is
yes,
naive B cells are also mature, and the plasma cells are also mature. So can you just
yes,
tell me if we have cancer of the naive B cells, what would happen? What surface marker are we going to see?
yes, it's for the naive B cell we're gonna see CD20 and exceptional CD5.
Perfect. Okay. Can you just tell me that what about a specific name for these cells? These immature, we hit them, right? We just slap
Yes,
them.
yes, smud cell.
Perfect. That's perfect.
And for
Are we going to see some like increased risk of infection or like lymphadenopathy
yes,
here?
yes, we're gonna
Okay.
see because of gamma globulinemia, we're gonna see high risk of infections, and because a lot of antibodies gonna produce, so some of them can affect our own body, okay, like autoimmunity, so which can lead to autoimmune hemolytic anemia we can see, and moreover we can see lymphadenopathy.
Okay. What about hairy cell leukemia? The concept
Yes,
in the story which we made that it's like more mature. That was a concept we were making, right?
yes,
Can cause
yes.
yes. Okay. So what about hairy cell
So we
leukemia?
said yes. So we said that the plasma cells are like more mature than the naive B cells. And
Okay.
but in our story, we said the mature person, he has hairs, and this
Yes.
mature person, they have one ability to trap people. So what
Yeah.
happens in the plasma cell leukemia? I mean, in the hairy cell leukemia. So these hairy cells, they kind of they trap, okay, in the spleen, which leads to splenomegaly, and the trap stands for tartrate resistant acid phosphatase.
Okay, so it was just a story which we are building, right, for the mature and less mature. So basically, the idea is you can have two variants of these mature, right, for the naive B cells and for the mature B cells, right?
Yes.
Or yes, or for the plasma, you can also refer it to plasma. So that was all for today. Or did you guys enjoy the white blood cells and the leukemias?
Sir, I have a question.
Hello?
Yes, sir, I have a question.
Yes.
So, sir, you basically said that the naive B cells, like we built a story around that they are slapped and then they become the smudge cells. And then their
Okay.
neoplastic proliferation. Did I hear it right that you said that when their neoplastic proliferation occurs, so it results in CML?
CML?
Like, did I hear it right or it's CLL?
No,
The neoplastic.
no. I didn't say CML. Tomorrow we are going to discuss CML in detail. It have nothing to do with these B cells, right? Sorry if
Okay,
I
so
just said that.
no, I think I heard it
Yes.
wrong, maybe. But the thing that I was actually pondering upon was that we discussed that naive B cell causing this disease, and we also discussed hairy cell leukemia. But we did not
Okay.
discuss anything that is caused by naive T cells, right?
Okay. So tomorrow we are going to do that. Don't worry
Tomorrow.
about that.
Okay,
Yes.
okay. I thought I missed a point.
No. So we have just did like tell the B cells, and tomorrow we'll be, just doing that. Okay. So thank you.
Doctor, can you hear me?
Yes, please.
So, doctor, I have one question. So, the lymphadenopathy and hemolytic anemia, they are found in both naive B cells and plasma cells leukemia, or it's just the immature naive B cell which cause the smudge cells? So, it's only caused by the naive B cell or the plasma cell leukemia
Hello.
both?
Hello. I'm back again. I just got disconnected. Yes. Can you just ask the question again, please?
Yes, can you hear me now?
Yes, I can hear you.
Yes, so the lymphadenopathy and hemolytic anemia, they occur in the chronic leukemia of naive B cell or the chronic leukemia of plasma cells or the both?
Naive B cells. For the plasma cell, you see splenomegaly. Or the mature hairy cell, you see splenomegaly. Lymphadenopathy occurs in for naive B cells.
So is there any logic that lymphadenopathy occur in naive
Okay.
B cells, not in
This
the plasma?
question's already okay. This question was already asked by someone else, but for that I just told you, right. For the B cell, for the naive B cells, you can simply think of, right, that naive B cells, where do they sit? They sit in primary follicles, right. If you have cancer, primary follicles are a part of your lymph nodes, right. If you have cancer, your lymph nodes are going to enlarge, right. But the plasma cells, they basically keep roaming around here and there, like sometime in the spleen, right.
Okay.
Hello.
Yes.
And as they are hairy, they're trapped, right. So what happens, these cancerous cells can trap within your spleen, but naive B cells do not move. They sit
Okay.
there, right.
And what about
They sit in the
hemolytic
lymph nodes.
anemia?
But for hemolytic anemia, we discuss if the naive B cells, or okay, so naive B cells are the immature, the 25-year-olds B cells, simply, right. If you are, destroying, or you have neoplastic processes going on in the mature people, so we know that in the future they are going to be like more mature plasma cells. In the future, they'll be making antibodies. So if you are just disrupting the ability of an individual in 25 years of age, so it's obvious at 60 he won't do anything. So at 60 years of age, he can't make antibodies. You are going to see like hypogammaglobulinemia and further in future, right?
Okay, thank you.
Increased risk of infections.
Thank you.
Okay. Okay, so this was all about today's lecture, and hope so you guys enjoyed. And if you guys have any problems, so tomorrow we are going to discuss the remaining one. Thank you so much. Thank you so much. I'll be just sharing the schedule in a while, and you guys can just start, doing your UL MCQ. You guys can just take a rest. You already had a lot, a big session. So I'll also just take some rest, and you also, right? Thank you so much. Have a nice day. Bye bye.
Bye, doc.
Thanks, sir.
Do we have UL discussion right now?
Yes, we are going to have UL discussion right after like 1 hour. I'll just, you guys can just take rest. Please take rest for 1 hour, right? Right after 1 hour, I'm going to come and we're going to do UL discussion in where?
Discord.
In the Discord, right? I'm just waiting for you guys.
Okay, just text before the start of the discussion. Thank you.
Yes, I'll just text it in the group. Don't worry about
Thank
that.
you.